On behalf of the Speed Medical Institute and for the subject of radiology, today we will be discussing the INI-CET PG 2021 November session. The exam happened just a few days back. It happened on 14 November 2021. Today what we will be doing is, I will be discussing with you all the radiology MCQs that were asked in the exam. We will be discussing the authentic MCQs and I will be providing you the authoritative answers. This is going to be a worked format today. That means I will be presenting you the question, 4 options, the correct answer, as well as the explanation needed to crack the MCQs. So you can just sit back and relax and go through the discussion today. And here is myself, Dr. A.Aditya. I will be your radiology faculty taking you through the classes. Let's proceed ahead. Friends, today the first question for discussion is, identify the true statement regarding CORADs. So my discussion, how it is going to be is, I will be telling you the question, I will be decoding the question for you. All the 4 options I will be decoding. I will be telling you the correct answer for the MCQ as well as the explanation needed. In that, what I will do for you is, I will decode the examiner's mindset, like what they are expecting from the PG aspirants and why they came up with such a question, and what is the correct answer, how to eliminate all the other answers and come to the conclusion. Okay. Here the first question is, identify the true statement regarding CORADs. Friends, here CORADs, first you must know what is CORADs. CORADs is a system used in radiology. It means COVID-19 reporting and data system. Okay, same like that, we have universal systems for lot of organs, for thyroid, thyroids, for prostate, pyrites, and like that. Here the given options are, pleura thickening is the common finding, unifocal lobar consolidation, CORADs 0 is normal CT, and CORADs 5 is typical of COVID. The examiner wants to test you that which is the true statement regarding this ones. So in the 4 options they have given, one is going to be the correct answer and other 3 are going to be the wrong answer. So there are 2 methods to crack questions like this one. Either if you know which is the correct answer and you are sure about it, you can mark it, or you can eliminate all the 3 options which are wrong. So in this case, what we shall do is, you must know 2 things here. That is what they are coming to test you here. First thing is, you must be familiar with CORADs system, friends. Okay. CORADs. It is used in radiology department for whether the patient affected is having COVID-19 or not. Whether he is suspected of COVID-19 or not, the predictability rate, whether he is having COVID or not. Remember it very carefully. CORADs is not to determine the severity of COVID-19 infection in the particular patient. Okay. This is an important MCQ. They have not yet tested, hence I have given you this. Just remember, it is not for severity of COVID-19. Okay. Now let's get to 111. Friends, if you look at the MCQ there, they have given CORADs 0. Remember, in CORADs system, we do not have 0. It starts from 1 and ends in 6. Surely it is very difficult for you to remember, because in the entire PG preparation curriculum, you will have a lot of data which have been classified in a tablet column. Some things will be starting from 0 and others from 1, but you have to remember it. CORADs starts from 1. With this itself, you could have eliminated one of the options there. Okay. Now I will explain you how. CORADs 1 means there is no suspicion of COVID-19. So the HRCT, high resolution CT scan we performed on the patient will be normal or there is no trace of any infections. Okay, there is no trace of infections. Some abnormalities could or could not have been present. Okay, now we are going to Codex 2. Here there is low suspicion of COVID-19. So here what you must understand is the HRCT scan of the patient is found to be having infection. Okay, but infections other than the COVID-19. First thing is HRCT had abnormalities but no infections. Codex 2 is infection is present but is not like COVID-19 pattern. Codex 3, friends. Codex 3 is a indeterminate. It is a borderline. The borderline between whether COVID-19 is present or not. So remember here in Codex 3 is the borderline. So let's go to 4. 4 is high suspicious of COVID-19. Here you are able to see abnormalities in the CT scan which are suspicious for COVID-19. And Codex 5 is very high suspicion of COVID-19. That is typical of COVID-19. And another important question what they can ask you in exam is Codex 6. It is the integration of radiology with a pathology report. Okay, microbiology in this case. If the patient has undergone nasal swab and oral swab and it is found to be PCR positive, that means real-time reverse transcriptase polymerase chain reaction positive, PCR positive, then we term the HRCT reports as Codex 6, friends. Okay. Now, next thing what you must remember is, if you want to have crack on that question, you must have known this. You should have revised at least once this one. And next thing is this slide. For this specific question, I have gone through all the resources that were available on COVID, and I have come up with all the typical findings a COVID-19 infection presents with. Okay. What are these, friends? Just you can remember it. These are multifocal, many foci of ground glass opacities in the HRCT. These all are HRCT scan patterns and pathologies. Okay. So multifoci of ground glass opacity is typical of COVID-19. If it is peripherally distributed in the lung, it is typical. Basal distribution in the lower lobes, it is typical. Unsharp demarcation. So in a HRCT report, you are able to find normal lung tissue, followed by that there is a foci of infection. And the margin is not sharply demarcated, it is unsharp. That means that is typical of COVID-19. Vascular, blood vessels undergoing thickening, and the foci appearing round in shape. Crazy paving pattern, ground glass opacities are all typical of COVID-19. Okay, ground glass and consolidation. Remember, friends, reverse halo. For your level, just remembering these findings is more than enough. You need not interpret in a CT scan. That is our level. Okay, and spider web appearance. These are all typical of COVID-19. Why I am teaching you all this is how you will be able to crack the question. Next, what are the atypical findings? I have classified as two for you, atypical and very atypical. Friends, this means whenever you come across these patterns in a HRCT, they are not towards COVID-19, they are towards other infections and other pathologies. Okay. So what are they? They are central distribution. Peribronchovascular, around the bronchovascular area distributions, more apical distributions, presence of lymphadenopathy. And look at here, I have bolded it for you, unifocal, a particular foci, that means a particular lobe undergoing consolidation. These are all atypical of COVID-19. That means a COVID-19 infection and these patterns won't go together. Some other infection or pathology would have been there. And what are the very atypical findings? Pleura undergoing thickening, cavitations, calcifications, tree in bud appearance, bronchiolitis, nodular pattern and mass. Okay, these are very atypical. So look at the bold part, pleural thickening I have mentioned here, and unifocal lobar consolidation I have mentioned. These two are very atypical, right? This have been asked in the question as options. Okay, now let's get there. So pleural thickening is the common finding. It's very wrong, friend. It is an atypical finding. Okay, hence this option is wrong. Unifocal lobar consolidation. So whenever they give something blindly like this, it means they are coming to say COVID has unifocal lobar consolidation. That is also rare in case of COVID, hence it's a wrong option. Corax 0. I have told you earlier, it starts from Corax 1, 0 is not there. Hence, this is a wrong option. And Corax 5, typical of COVID, is the correct answer, friends. So, the examiner's mindset here is, right now we are living in the pandemic of COVID-19, hence they have come up with a Corax question. But what they are expecting is, they are a little bit high from you. On a radiological perspective, they want you to know what is Corax. How Corax is, like what are the number it is there, Corax 1, 2, 3, 4, 5 like that, types of Corax, and what belongs to what, and what are the typical findings and what are the atypical and very atypical findings of COVID-19. This is why they have come up with this question. If you revise my next two slides which I have discussed with you, you will be able to crack these sort of questions in the upcoming future funds. Okay. Now let's get to the next MCQ. Okay. The question here is, identify the neck investigation being done. Okay. Friends, here you must understand that in radiology, sure shot I will tell you, if they are asking you 10 to 15 questions, at least 1 to 2 questions will be on this category. What it is, they want you to know basically what is the image, whether it is an X-ray image, whether it is an ultrasound image, whether it is a CT image, MRI image, or any special investigation. It's what to say, it is a basic for PG aspirants level. Okay. So when I discussed with the students from SPEED, I hear that they did not give you the labeled items in there. Just a diagram like this was given. Friends, whenever they come up with such a diagram, I want you to remember that this is we are putting an ultrasound probe, that is a linear probe on the neck area, and we are looking at the what are the structures present here. For example, the common carotid artery, internal jugular vein, and the muscles around it. Okay, I will show you the image later, but this is like a short. It's a ultrasound scan. Okay, it is not an X-ray scan. I will show you all the images. It's not a CT scan nor a fluoroscopy procedure. Hence, the correct answer for this question is ultrasound scan, friends. And a little bit of decoding this image for you. Exactly what we have done is, we have used a linear probe, friends. Ultrasound make use of probe, right? Here we are using a linear probe, and I have taken the probe and I have put it here. Okay. So what happens, we are able to see the muscles in that area, that is the sternocleidomastoid muscle. This is the sternocleidomastoid. Okay, and this is the sternothyroid muscle. This is the tracheal ring that is present here, and this is the lobe of the thyroid. Okay, and this is the common carotid artery. This is the internal jugular vein. Okay, this and all have been given in this image. Now let's exclude the other options. Okay, friends, look at this image here. The first image is a typical image, you all will be familiar. It is a X-ray. X-ray of neck. AP view. X-ray taken like this, and another X-ray taken from lateral view like this. Okay. So these are the two images. The first image is a X-ray AP. The second image is a X-ray lateral. Now, I will take you to another of the option, that is fluoroscopy. Why the given image is not a fluoroscopy is, friends, remember, whenever a patient has a pathology related to the bones in and around surrounding the neck area, we perform a basic X-ray, because X-ray will be able to look at the bones well. So we'll perform it and we'll be able to come out to a conclusion. Whenever we have problems related to deglutition, the soft tissues of the neck, that is the oral pathway, then we perform a fluoroscopy. Here, what you must understand is the fluoroscopy procedure is, it is a dynamic procedure, real-time procedure. I'll explain you. We will take a video with the help of X-ray. Remember this. So what we will do here, let's say I have a patient here. I will ask the patient to drink the contrast. And when the patient drinks the contact, it enters through the oral cavity and goes through the oropharynx, then it will enter through the esophagus, right? That area we will be able to see in a fluoroscopy image. Here I am able to give you a static, just a image JPEG format, but it will be a video like. So what I will be able to see, since the contrast go through the pathway, I will be able to look if any abnormality is there, any pathology is there. Okay. So here what we have done is the bones, right? The bones, we are not interested in bones in fluoroscopy. Hence, what I have done is I have suppressed the bone. So it has become black and I am interested in this area. This is the deglutition pathway. Okay, remember it. I am interested here, I am not interested here. That's why here bones are appearing black and the pathway which I want to know is shown in a white format. And when I give contrast, the contrast will glow, it will be appearing black and it will be present here and there. Through that I will be able to identify whether any pathology is there or not. And what is the third image I have given? The third image is, this is how we will perform an ultrasound of the neck. This is our ultrasound machine and here is the patient lying, and this is how we will put the probe and we will be looking at the screen for whether what are the things present there. Okay, we will be looking at the thyroid, tracheal rings and the arteries, common carotid artery and the internal jugular vein and muscles around it. Okay, now let's get to the fourth option given in the question, that is a CT scan. Friends, here what I have done is, first you must know how I am saying this is a CT image. Always look at the bone part. Okay, the bone part will be appearing very white. In CT term, we call it as hyperdense, friends. Okay, and what are the three views I have given you here? This is a sagittal view. Okay, take them like this, cutting the patient in half like this. So this is a sagittal view and this is an axial view of the CT scan of the neck, sagittal view, CT scan of the neck, and this is the straight away coronal view CT scan of the neck. Hence understand here, we have discussed each and every option regarding the question. These are all the CT images. Look at the bone part, it is appearing very white and it is more, we are able to see lot of soft tissues in and around it, and the bone is appearing very white here compared to X-rays. These are CT images, and this one, the above one is X-ray neck AP view, X-ray neck lateral view, and this is a video image of fluoroscopy, and this is a ultrasound image of the neck. Okay, hence if you look at the question part, that's how we come to the answer. This is an ultrasound scan. It's not a X-ray, not a CT, not a fluoroscopy. Okay, now let's get to the next question. Remember, in whatever exam it comes, at the level of post MBBS curriculum, PG entrance, whether it may be a FMG exam, next PG exam which is about to come in the near future, or INI-CET PG, there will be a question from radiology testing you what scan is given. So be sure that spend some time and have a good clarity like what is the image, which modality does the image belong to. Okay. Now let's get to the third question. A 30-year-old male patient came with increasing abdominal pain for past 3 days. After fighting with bull, was what some people were saying, a bull attack or hit by bull, had obstipation for 2 days. Nausea, vomiting with a severe pain, abdomen appears to be rigid. Chest X-ray radiograph is given and they have given you 4 options and which is the correct answer. Okay friends, here the examiner's mindset is they want you to know the common radiological emergencies which we encounter in a day-to-day thing. So our third topic which you must remember is you must be very much thorough with the radiological emergencies. A lot of radiological emergencies like pneumo. So what are they? Let's say pneumopericardium, pneumomediastinum, pneumoperitoneum, pneumoretroperitoneum and all. Okay. So this is what the examiner is trying to test here. This question has been asked left and right in the past exams, and these are the questions where you must not make mistakes, friend. These are completely easy for all of them, and if you make a mistake, your rank will go very behind. So these questions you should never try to make mistake here. Let's decode the question. A 30-year-old male, mostly active male who has been working in the farm or something like that. That's why they have given the age. That is the relevance of age here. Patient came with increasing abdominal pain. Okay, he's having abdominal pain for past 3 days after fighting with bull. Okay, that means he has endured trauma. That is what they are about to say you here. So the patient would have undergone trauma which leads to some problem inside his abdomen. And you must be clear with the term obstipation, which I will discuss with you in the later slide. You would have heard in your undergraduate days constipation, but this is obstipation. So it is like incontractable constipation. Okay friends, I'll tell you. 2 days he had nausea and vomiting with severe pain and abdomen is appearing rigid. These are all the symptoms which are going towards pneumoperitoneum. Friends, what they have tricked here is, instead of straight away giving you the answer like pneumoperitoneum, they have given you hollow viscous perforation. Okay, many will be clear with this, but I will explain to you. Inside our abdomen, we are having a lot of hollow viscous organs. Whenever these organs undergo perforation because of any reason, most probably a trauma, what happens? Through the bowel, okay? Through the bowel, because of damage here, the air will enter outside. So what happens? Let's say this is the abdominal cavity. Abdominal cavity, this is the abdomen, and you are having the lungs here. One minute. Okay, let's say this is the abdomen of yours and you are having the lungs here. What happens? You are having bowels here. So because of some damage, you are having trauma here and the air enters. Always remember, air enters anti-gravity towards the top. Fluid goes towards the gravity of the most dependent region of our body. So here the air has gone up. It will go to the diaphragm friends. This is how the diaphragm will be and the air will get accumulated here. Okay, this is how it will be appearing. So when you look at the radiograph images, you are able to see a chest radiograph and this is the diaphragm. Okay, the crux of the diaphragm, both sides. And below that, I am able to see blackish area. So in a radiograph or a CT scan, if you are able to see a black thing, it is air. So this means the patient is having a pneumoperitoneum, hollow viscous perforation. This is how I have come to the diagnosis of hollow viscous perforation, and how I am excluding the other option is empyema thoracis. Empyema a pus collection in the thoracic cavity. Do you think you are able to see anything here? No. So this is not an empyema thoracis. Traumatic diaphragmatic rupture? No. I am able to see both the domes of the diaphragm very clearly. So it is not an answer. And I'm not able to see the stomach part getting twisted here, okay, like organoaxial or mesentericoaxial, hence gastric volvulus is not answer. This is how I am coming to the answer of hollow viscous perforation first. Okay, now we'll discuss little bit clinically. Let's say you are a house surgeon and you took a patient to the X-ray department and took a X-ray, and you are able to see such an image, and below the domes of the diaphragm you are able to see air. So straight away you will be jumping like this, yeah, I have found pneumoperitoneum. Okay, that's a great thing. Sure, that's a great thing. You have found radiological finding, but I will tell you some clinical areas where you can normally get pneumoperitoneum. So what are they, sir? So each and every hospital in our country will be left and right performing a lot of surgeries. In that we'll be doing a lot of abdominal surgeries. In the abdominal surgery, let's say this is the abdomen, we will be opening the abdomen first. So what happens? Normally air enters, okay? So a residual amount of air will be present inside the abdomen after finishing the surgery also. Most of the air will be resolved while some may be present, and post-operatively, from the surgical department, they will be doing a radiograph. Why? Now it's applied forensic medicine, res ipsa loquitur. The thing or fact speaks for itself, right? So if you leave a gauge there, a scissor there, or anything like that, for that purpose, they will be performing a post-operative X-ray of the concerned area. In our case, since they have done abdominal surgery, abdomen. So that time you will be able to see a little bit of residual air below the diaphragm. Hence, pneumoperitoneum will be a normal finding or a common finding in case of post-operative patients. This is what you must remember. Normal in case of post-operative. Now I will put you a tricky question. Can you produce artificial pneumoperitoneum? Artificially, whether you can produce pneumoperitoneum? Yes, we do that in case of laparoscopic surgeries with the help of carbon dioxide. So these are all points which I collected which have a MCQ relevance for your level, okay? Hence we have come to the answer of hollow viscous perforation or pneumoperitoneum. But what I want to discuss with you here is, which will be left by most of those, that is obstipation. Friends, obstipation, I took little interest here because constipation you all know, but obstipation, many will just neglect the word and go, but you should not make the mistake. Being a speech student, I want you to know each and everything what the examiner is trying to confuse you with, and you must come to the correct answer in a short span of time. So obstipation is intractable constipation. So, sir, what is intractable, sir? Intractable is resistant to cure, control, or give relief. So, the constipation which is very resistant to cure, control, or relief is called obstipation. Okay. So, till now we have discussed three concepts. One is radiological emergencies, which scan image is given there, and the important topic right now, which is a pandemic, is Codex. So all till now has been a very important questions which you must be knowing as a radiology when we are covering a radiology subject. Now let's enter to a very new pattern of questions which they are asking in right now pattern, friends. I have seen a lot of questions 2018, 2019, 20, and being in 2021, what they are doing is they are slightly moving from X-ray ultrasound towards CT scan. So what is the trend, friends? CT scan, if you ask me. In that what they do, whether they give you an image and ask you what scan is that, or they give you a radiological anatomy, okay, and ask you what is the structure mark. Now let's get to the fourth question. This is a evolving trend right now. Be careful here. Identify the structure marked in the given image, friends. The four options they are given is Onodi cells, pneumatized superior turbinate, concha bullosa, septal turbinate. And many people would not be very much familiar with, sir, what is this image, sir? It looks very much difficult for me to interpret. I don't know what they have given us. I'll tell you. They have performed a CT scan on a patient, that is the head part, and what they have done is they have cut like this. Okay, this is a coronal section. I mean, they have cut like this. Coronally they have cut, and at this level they have given the image. Okay, so for your reference I will tell you, this is a CT scan image orientation. It's a coronal image. Okay, and which area, sir? It's in and around paranasal area. Okay, so exactly around this area they have given. So I will tell you a little bit of anatomy here. We'll be discussing it in detail in the upcoming slides. Friends, here you are able to see, right? These are the both the side maxillary sinuses. Bilateral maxillary sinus. Okay, and you are able to see a bony part here, right? These are the bilateral inferior turbinate, and the above part here, this is the middle turbinate. You should not expect very symmetrical. Each and every human being is different. So little bit it won't be symmetrical, but these are the parts. And here we are able to see the superior turbinate part. Okay, friends. What they have marked is they have marked a black structure. As I told you before, in X-ray and CT scan, if you see a black structure, it is air. So this is straightforwardly, the answer is pneumatized superior turbinate. Okay, for those people who are not very much familiar with the CT anatomy, I will tell you certain tricks which will be very helpful for you. First thing is, always remember, bones calcifications are going to be white in CT. Air is going to be black in CT. And soft tissues, okay, in case muscle I am saying, will be gray in CT, and fat will appear grayish black or blackish gray in CT. These are the things you must remember. These are shortcuts. So friends, just remember, they have marked a structure which is appearing black in CT, hence air is there. That's how I have come to the answer of pneumatized superior turbinate. Either you must have a radiological anatomy knowledge, or you must have shortcut tricks like this. Now I have told you what the correct answer is. Now let's look at the other options. First, friends, a little bit of MCQs regarding pneumatized superior turbinate. Pneumatization of superior turbinate is a cause of migraine headache. Not very much up to your level, but in day-to-day practice, as a radiologist, I must be knowing this is one of the main significance regarding pneumatized superior turbinate, and you need not know much about it. Let's get to other things. Other options. We had concha bullosa, right? And here I am presenting you an image where you are able to see same coronal CT scan looking at the paranasal sinus, and this is how bilateral concha bullosa appears. Okay, bilateral concha bullosa. First point what you should know is concha bullosa is a pneumatized middle turbinate. Okay, I showed you the middle turbinate. If it is having pneumatization, it is called concha bullosa. If it is appearing on both sides, it is called a bilateral concha bullosa. And remember, on applied ENT, concha bullosa is the most common pathology in the nose. MCQ. And in the option they would have given like inferior turbinate, which is the largest turbinate, which is the MCQ. Among the following, which is the largest turbinate? Inferior turbinate. And anatomy wise, it is a separate bone, MCQ. Okay. And remember here, what is concha bullosa, sir? Many people won't touch out there. I want to say that concha in anatomical nomenclature means shell-like, seashell-like. Okay, a cystic distension of the, if it is bullosa, cystic distension of the middle nasal concha. Okay, where, sir, it will be seen? You are telling it is the most common pathology, so where it will be seen? In chronic cases of rhinitis, I will be able to see bilateral concha bullosa. Okay, and regarding friends, what I want to say you here is, this is the fourth pattern of MCQ which we are seeing, and this is all typical patterns they used to ask. The fourth pattern here is radiological anatomy. You have to be sure, friends. Okay, my advice to you here is, at least know basics of paranasal sinus CT anatomy, which I have discussed in my classes, and know about abdomen CT, pelvic CT. They will just mark an organ. You will be knowing it left and right. Let's say they will mark stomach and they will ask you. You will be confused. So what is that? And you will leave it and come. So just to go through the radiological, the thing is radiological anatomy, and see what are the organs, how it will look like. Okay. And the fourth option which was given in the question was Onodi cells, friends. So for your purpose, I have added what are Onodi cells. Onodi cell is a posterior ethmoid hair cells. There are a lot of ethmoidal hair cells like Agar-Nasi cell, Haller cell, Onodi cells that lies superior to sphenoid sinus. Okay, and is seen in close proximity to at least one optic nerve or internal carotid artery. This close proximity of the Onodi cells to the optic nerve and internal carotid artery is a risk factor for surgical complications. What I want to know you to know here is, see here, the lines and the diagram just match with itself. The Onodi cell is a posterior ethmoid hair cells. The ethmoid hair cells, no, they will be present anteriorly and posteriorly. Okay, so that lies superior to the sphenoid sinus. Here you are able to see the sphenoid sinus, and nearby you are able to see the Onodi cell. The structure which I am marking here, it will be appearing black. Okay, it is superior to sphenoid sinus and is in close proximity to at least one optic nerve. Friends, it will be very difficult for you to grasp optic nerve here, but I will highlight it. Look above the Onodi cells, you are seeing right. This is the optic nerve. They won't ask you, just this diagram say I am saying you, Onodi cell will be lying very close to optic nerve, and it will be appearing very close to internal carotid artery. That's why while performing laparoscopic operations of this area, you can damage the Onodi cells, and that leads to either damage of internal carotid artery or optic nerve. Both are very serious complications. That's why that is the importance of Onodi cells. Okay, applied ENT. Okay, now let's get to the next question. This question I have discussed numerous times with you. Here what they have done is, they have gone to biochemistry level at the level of a cell cycle, and they have asked you which phase of the cell cycle is least radiosensitive. Okay, let's look at the question. In the cell cycle, which is least radiosensitive? Okay, now for your purpose I will add here. Look at it. radio sensitive, radio resistant. Okay. The question what they have asked is, which is least radio sensitive here. So, as a medico with a very developed brain, you must understand they're asking, which is the most radio resistant. Least radio sensitive will be most radio resistant, and the least radio resistant will be most radio sensitive, the opposite. Okay, that's why I'm drawn this diagram. Okay, for this question the answer is synthesis phase of cell cycle, friends. We'll have a brief discussion with this in the next page. At this level the answer is S phase. M is not the answer, G2 phase is not the answer, G1 phase is not the answer. How, sir? Look at this diagram, just a description about the cell cycle. It starts at the G1 phase first. First gap growth phase. Then it goes to synthetic phase, synthesis phase. From the synthesis phase it goes to G2 second gap growth phase. From the G2 phase, the cell goes to mitotic phase. Okay, this diagram is very important. I will touch upon it. So, the most radio sensitive phases, look here, observe here, early M phase. Early M phase. The early part of M phase. Okay. That phase which goes towards the G1 phase, that phase is the most radio sensitive. Don't look at the other points here. Okay, and the most radio resistant will be the late phase of S. So if I want to make this question even bit tougher, next time what I will do, the option is M phase, early S phase, late S phase, G1 phase. That's very hard, but you must remember, because this is how the trend is going. Same question, little bit harder, they're asking the next time. So that's why I have also gone little bit depth here. In the next slide you will be able to appreciate it very better. Cells, remember this slide, it is very important. Cells in the S phase. S phase, remember that to end of S phase. They are most radio resistant phase of cell cycle. Next, M phase, mitosis phase, right? M phase, most radio sensitive phase of cell cycle. In that early M phase is most radio sensitive. Now it's going to be a little bit interesting for you. I have integrated radiology with all the first year subjects, and let's crack this. Genetics from anatomy, physiology and biochemistry. If a cell undergoes radiation, X-ray, CT scan, while the cells are in G1 phase. What phase? G1 phase. The cells will have chromosomal abnormalities like trisomies. Trisomy 18, Down syndrome, trisomy 21, Down syndrome, trisomy 18, Edwards syndrome, trisomy 13, Patau syndrome, 45XO Turner syndrome, 47XXY Klinefelter syndrome. Like this, the patient will go for, the cell will undergo chromosomal abnormality which will manifest as these syndromes. Remember, G1 phase, chromosomal abnormality. Like that, when the cell is in a G2 phase, the cell will undergo chromosomal aberration, that is chromatid going for aberration. For your knowledge, what are chromosomal aberration? Cell undergoing, that chromosomes undergoing duplication, deletion, inversion, translocation, those are abnormalities. So these are all the points I collected regarding the cell cycle and radiology. Next, another thing is, from the latest edition of Harper, I was able to find that one specific line is given. You have to remember it by heart, because sometimes they can give you same option like this and ask you which is the correct statement. G2M phase, okay, are most susceptible to radiation injury friends. Okay, so this is all the MCQs that are asked in the past regarding cell cycle and radiology. Now let's move ahead to the next MCQ. Okay. Here, this is a very controversial question, friends, because one group of students were saying, sir, it was a 55 years old male, and another group was saying it is a 75 years female, sir. And among that was a very studious girl who was staying, and she is very hard worker. She was saying that, sir, I can say 100% it was 75 years old female. Anyway, I will be discussing both the answers which differ because of age with you, and we'll come to the diagnosis. Let's get into the question. This is little bit high for your level, friends. Okay, the question they have asked in the exam is 55-year-old male with a history of nasal obstruction for 3 months and occasional bleeding from nose. MRI was done, and what is the probable diagnosis? The options they are given are juvenile nasopharyngeal angiofibroma, inverted papilloma, squamous cell carcinoma of maxilla, esthesioneuroblastoma. So let's decode the question here. 55-year-old male, very important, friends. This makes diagnosis clincher. With the history of nasal obstruction, nose getting obstructed for 3 months, occasional bleeding from nose because of the mucosa getting damaged, MRI was done, and what is the probable diagnosis? They have given you an image, and many people are telling me, sir, that image was looking like predators, like that. But remember, MRI images, if you look in a dark field, it will be looking like that. But we have decoded a lot of MRI, and it won't be a trouble for you. And I will be saying you like how to find this. Okay. Next thing is the 4 options. Juvenile nasopharyngeal angiofibroma. That is the patient having a mass inside. Okay. So that one, inverted papilloma, squamous cell carcinoma of maxilla, esthesioneuroblastoma, that is the tumor that is arising from the cribriform plate of ethmoid bone. So the correct answer for this MCQ is inverted papilloma if they have given you 55 years old male. Okay. So what is the pathology, sir? Look here carefully. This is the brain part, normal brain part. Okay. And these are your eyeballs at the level of their basement. And this is the same CT scan I showed you, right? Paranasal sinuses area. Okay. Here you are able to see a mass, right? Inverted mass. This one which is present on the left side. This is the inverted papilloma in this case. Okay. It's a typical image, friend. If you even Google it, inverted papilloma MRI image, second image in Google will be this image. So what I have analyzed through this INI-CET paper is most of the images were from the Google first or second image, friends. So they have not gone very rare images, straightforward things only, but it needs little bit of more preparation from you. Hence the answer here is inverted papilloma. Let's discuss ahead. It will be very interesting. So look at the option: juvenile nasopharyngeal angiofibroma, inverted papilloma, squamous cell carcinoma. I will tell you how to differentiate. First thing, adolescent male presenting with the mass, suspect juvenile nasopharyngeal angiofibroma, friends. More specific, 14 years has been a median for this disease. Adolescent male having a mass is juvenile nasopharyngeal angiofibroma. Next thing is inverted papilloma. Our question, 40 to 60 years male. I went through some of the latest scientific articles regarding inverted papilloma and I found out that males are more common for this disease than female at the level of 3.5:1 ratio. It's not for you, just remember males are very commonly having inverted papilloma. Then squamous cell carcinoma will be more than 60 years. Okay, if the patient is more than 60 years and you are able to see a mass which is arising from the maxillary sinuses or from either of the side, high chances squamous cell carcinoma. And another thing is ethmoidal polyp. Okay, 20 to 40 years. Ethmoidal polyp will be there. So from this itself I have excluded options like juvenile nasopharyngeal angiofibroma because the patient is not nearly adolescent male or 14 years like that. Then squamous cell carcinoma of maxilla because it is not more than 60 years like that. And inverted papilloma because it is confining to 40 to 60 years and the appearance which I will discuss with you in a short time. Esthesioneuroblastoma won't look like this. That's how we will be cracking this. It will be arising from the cribriform plate of ethmoid bone. They would have given such an image. It is very high for your level, hence we will exclude that option. The correct answer is inverted papilloma. Okay. What you must remember here is, what is papilloma, sir? Papilloma is a benign epithelial neoplasm. A benign neoplasm which is arising from the epithelial cells having finger-like projections or verrucous warty projections from the epithelial surface. A special type of papilloma is inverted papilloma. Papilloma in which the proliferating epithelial cells invaginate into the underlying stroma. They will invaginate. It usually occurs in the, what are the locations? This can be asked in the future questions. It can be present, inverted papilloma, that special papilloma can be present in the nasal cavity, urinary bladder and oral soft tissue stones. In that case, in case of oral cavity, it is called inverted ductal papilloma of middle-aged males. So what they are coming to say is inverted papilloma itself common in 40 to 60 years male, middle-aged males. Okay. Applied ENT, what I want to discuss with you here is the inverted papilloma of nose is also known as Ringer's tumor. You must remember it. It's a benign tumor of nose with very malignant potential and it is arising from the lateral wall of the nose trunks. These 3 points are MCQ. Also known as benign tumor of nose with malignant potential arising from lateral wall of nose. I have given you both the images. The first is the MRI image, second is the CT image. Same tumor. See here, in MRI it is present here. On the left side it is present here, right? Same here, we are able to see on the left side of the nasal cavity, it is occupying here, okay? This is a typical image of inverted papilloma. If they want you to identify inverted papilloma, they won't give this image because with this image you can't say whether it is inverted papilloma or any other tumor. That's why we take higher modality like MRI where we will be able to see the color changes and the pattern changes and the location from which it is arising, all pointing towards inverted papilloma. Okay. Now let's get to the next question. This is also a typical question from INI-CET. Have been asked a lot of times in the exam, and I will discuss with you a lot of things in depth so that you will be resistant to INI-CET and you will be cracking the exam very easily. Here, the question they have asked is most common cause of bladder outlet obstruction in male neonate is. It's a single liner question. Most common cause of bladder outlet obstruction in neonatal male is posterior urethral valve. Okay, so if you know that line itself, you can crack this. Otherwise, cracking such a question is difficult because these are factual questions. Factual questions, if you have pre-knowledge, you will be able to crack. Otherwise, it's very difficult. Sitting on the exam and trying to crack a factual question is very, very difficult. It's like based on luck. My advice is I want to encourage you cracking a factual question in exam. Conceptual question, applying your brain helps. Factual question, cracking at the time of exam in a given time of like 1 minute, 30 to 45 seconds, 60 seconds, it's very difficult. So straight away the answer is one-liner posterior urethral valve. Hence we are removing the other options. I will also discuss with you other options. First of all, what is posterior urethral valve, sir? It is an abnormal congenital obstructing membrane presenting in the proximal part of male urethra. First of all, diagram. This is the bladder. This is the posterior urethra. What happens in abnormally there will be a congenital obstructing membrane, okay, which will be the posterior urethral valve, giving dilatation of the posterior urethra, as well as bladder will be having the contrast. If I show you the image, you will be able to understand it better. Look here. It is exclusively the disease of males. Very classic. Important cause of bladder outlet obstruction in infants. Infants male. Here, friends, you must understand two things. I will say you a clinical scenario. The pathology here is posterior urethral valve. Suppose, let's say, a pregnant woman, okay, she is pregnant, she is coming for an antenatal scan. You are doing an antenatal ultrasound before the pregnancy has happened, right? The antenatal ultrasound. And, sir, whether we could find posterior urethral valve in antenatal ultrasound? The answer is yes, you can find out. How, sir? They have given a special appearance for it. It is called the spinning top appearance. Okay? How it will be? Here, you are able. This is ultrasound image, which is showing a ultrasound image, which is showing appearance like this. Okay, the same image appears like this. Okay, so what is this part, sir? This part is the bladder, and this is the dilated posterior urethra. Okay, dilated posterior urethra. So this is the bladder, dilated posterior urethra. It will be appearing like a tap fence, a spinning top, like this. With this, we can have a suspicion as well as identify dilated prostatic urethra, which is the most important reason for posterior urethral valve. Okay, remember spinning top appearance, posterior urethral valve. Next, let's say the child has one. Okay, now the child is having urinary obstruction, urinary symptoms. So what we can do here is we can perform a study, a special radiology study called micturating cystourethrogram, MCU, postnatally, which will demonstrate a slit-like valve in posterior urethra. See here, this is the MCU image. MCU. These two are antenatal ultrasound. You are able to see bladder, urinary bladder having the dye, and the dilated posterior urethra having the posterior urethral valve here. Okay, and this appearance is called keyhole sign, friends. Okay, keyhole sign in case of micturating cystourethrogram is bladder and dilated posterior urethra because of posterior urethral valve. So 3 points I want you to take home. One is most common cause of bladder outlet obstruction in an infant male posterior urethral valve. On antenatal ultrasound, posterior urethral valve has spinning top appearance. On micturating cystourethrogram, posterior urethral valve has keyhole sign. Okay, let's get to the next. Here the same discussion, but I want you to remember it. Keyhole sign, when it is appreciated, sir, you will be performing a micturating cystourethropy, and the view you must take is an oblique view. Instead of a straight view, a little bit of slanting view like this. Okay, this leads to the appearance of typical appearance of keyhole. So this is, we will be applying our key, right? Keyhole sign is seen in case of posterior urethral. The next question. This is a little bit of high level question for you, which they have asked in the exam. The question is, patient with post-cholecystectomy status presents with surgical jaundice. Ultrasound is suggestive of dilated intrahepatic biliary radical dilatation and no gallbladder stone. To confirm the diagnosis, CECT was done, which is same as ultrasound finding. Next step is. Many students are confused with the question here. I'll explain you. Let's say a patient, he had undergone gallbladder surgery. So he is a post-cholecystectomy patient. Right now he is presenting with surgical jaundice, that is obstructive jaundice, also known as post-hepatic jaundice. Ultrasound is suggestive of dilated intrahepatic biliary radical dilatation. Sir, what is that, sir? Friends, we'll be performing, this is the right side. I will be performing the ultrasound. When I keep the ultrasound probe, I will be seeing the liver, right? In the liver, inside there will be intrahepatic biliary radicals and bile radicals. Okay, those branches have gone dilation. That is what they are coming to say, and no gallbladder stones have been found. Okay. To confirm the diagnosis, what they have done is, I mean, gallbladder stone means we have removed the gallbladder itself. That stone, whether it has gone while doing the surgery because of gallbladder stones, if any stone has moved out, enter the common bile duct, like that they are coming to see. Okay. To confirm the diagnosis, a CECT was done. Contrast enhanced CT of the abdomen was done, and it was same like ultrasound finding. No new findings were done. So what is the next step? Friends, this question has a little bit of conceptual knowledge. The next diagnostic imaging, which is not invasive, is MRI scan. Okay, mostly after a post-cholecystectomy status, if the patient is having a surgical jaundice, the reason will be either the stone had entered common bile duct or common bile duct clipping can be a reason. So in that case, what we can do is we can perform a MRI scan. MRI was the only word which was given in the option. Many students felt confused it seems. Remember, MRI means Mrcp, magnetic resonance cholangiopancreatography, or they can give the option of MRCP. Hence, we are removing PET-CT from here, endoscopic ultrasound, percutaneous transhepatic cholangiography. So as I told you, post-cholecystectomy status, having jaundice will be common bile duct stones or common bile duct clipping. A very interesting question I am going to discuss with you. When we perform a magnetic resonance cholangiopancreatography, MRCP, first of all, for contrasting between the different soft tissues, right? Bile itself will act as a contrast here. So we don't need any special contrast. First thing, okay? We don't need special contrast like gadolinium, okay, which is used in MRI, because here bile itself will act as a contrast. Next thing is a special test called MRCP juice test. Remember, friends, as a house surgeon, okay, or the upcoming doctors, whenever you perform a MRCP, my particular advice to you is ask the patient to drink a raw pineapple juice, that is a normal pineapple juice, and come for the study. So what happens here is, when the patient drinks pineapple juice, which is rich in manganese, Okay, manganese has the property of T2 relaxation time shortening. Two things you should remember. Manganese is rich in pineapple juice and the manganese is responsible for T2 relaxation time shortening. Okay, what it helps in when you drink pineapple juice, it goes through your oral cavity, esophagus, stomach, through the stomach into the duodenum, right? Duodenum will present near the common bile duct and the areas which we want to visualize. So in order to dull the duodenum part, in order to suppress looking at the duodenum and want to look at the biliary radicals, we will be asking the patient to drink pineapple juice. This pineapple juice will suppress the duodenum so that we'll be able to see better visualization of the biliary radicals and biliary tree. Hence, we can use pineapple juice. This can be a future question, very interesting question. That is called the Mrcp juice test in radiology. Okay. Next question is double blood sign in ultrasound is indicative of. So what is this double bleb, sir? That means it is appearing like this in an image, in an ultrasound. Okay. The four options they have given are amnion, yolk sac, amnion and chorion, 2 intrauterine gestational sac, heterotopic pregnancy. Friends, it's a factual question. Double bleb sign means amnion will be one bleb, yolk sac will be another bleb. Okay, but what I will do is I will decode the other options. Whenever we perform an antenatal ultrasound image in the first trimester, we will be able to find the double bleb sign first. It will be formed by amnion and yolk sac. Okay, yolk sac and amnion part, these both. At what times it will be seen? It will be seen at 5 to 6 weeks. In the entire obstetric radiology, whenever they give you weeks, it means on transvaginal ultrasound, leaving the probe inside the vagina and seeing. Okay, it is not transabdominal ultrasound. So remember, 5 to 6 weeks means transvaginal. It corresponds with the appearance of fetal pole. Double bleb sign corresponds with the appearance of fetal pole. So where will be the fetal pole, sir? Let's say this is one bleb, this is one bleb. It will be appearing here, friends. This is how the fetal pole will be. A tiny dot seen between the two blebs. Okay. During 5 to 6 weeks, what and all we can see, sir, is a gestational sac is visible by this time. Okay, on transabdominal scan itself. So whenever you go through obstetric radiology, that is ultrasound scan, and you are seeing weeks, 5 weeks, 6 weeks, 7 weeks, means it is transvaginal ultrasound, friends, unless specified otherwise. If they have specified transabdominal scan, means take it at that weeks. Otherwise, it is transvaginal scan. Yolk sac, secondary yolk sac is the earliest structure seen inside the gestational sac and can be visualized at approximately 5.5 weeks of gestational age as a round 3 to 5 mm structure. The yolk sac will be eccentrically located within the gestational sac, friends. This double bleb sign has been asked in the AIMS exam May 2016. What they have given is, I will discuss the same line MCQ point. The amniotic sac embryo yolk sac complex can be seen with ultrasonography as two small blebs. That is the double bleb sign of almost equal size attached to the wall of the early gestational sac, which is the double bleb sign. So what I have done here is I have consolidated all the points regarding double bleb in a single slide so that if you revise through these points, you won't make mistake. Next, heterotopic pregnancy. Okay, many people will make mistake here because they don't know what is the term is. Heterotopic pregnancy means combined pregnancy. Simultaneous existence of intrauterine pregnancy, that is a normal pregnancy, and a ectopic pregnancy. Okay, what I want you is revise this heterotopic pregnancy along with FM, friends, applied FM. What is that? Superfetation, superfecundation. Okay, revise it, because you should never make mistakes here. All have two things. That's why I want to stress here. Here, when you look at the ultrasound image, you are able to see this is the transvaginal ultrasound probe. You are able to see the uterus part showing the gestational sac, normal gestational sac, which is the intrauterine gestation. Also, you are able to see a ectopic gestation, extrauterine. Okay. You are able to see one pregnancy inside the uterus normal and another pregnancy outside the uterus, which is ectopic. These two things are called heterotopic pregnancy or combined pregnancy. Okay. Next slide. The another option they given is two intrauterine gestation funds. This is simple, straightforward. It's like a twin pregnancy. I have just given you the diagram, transvaginal ultrasound, giving you two fetus inside the uterine cavity, twin gestation. This is how it will be appearing, friends. It's a reconstruction image showing both of the fetuses inside the uterine cavity. Same image. Within the uterine cavity, if you are able to see two gestational sac, two intrauterine gestation, one inside and one outside, heterotopic pregnancy or combined pregnancy, and at the early stages of 5 to 6 weeks, very small, inside the gestational sac you will be able to see double bleb sign. Hence, I have cracked the other options. It is not two intrauterine gestation sac, no heterotopic pregnancy, and this is just a confusion here, not chorion. The answer is amnion and yolk sac. Okay. Next question, friends. Placenta accreta spectrum is diagnosed by. So, what I want to say is, in INI-CET exam, they have given you all typical radiology MCQs. It was not like other subjects like orthopedics or FM, where it was totally alien. Everything has been discussed before. It's very easier for students, it seems, to crack the questions. But I am just repeating for your purpose so that you know what is the correct answer for the MCQ. Here, the question is placenta accreta spectrum is diagnosed by. Typical radiology MCQ, the examiner mindset is he wants to know for this pathology which is the investigation that is best suited. X-ray? No. We will do a ultrasound. Okay. Pregnant female. Okay. The best investigations are ultrasound, ultrasound, ultrasound. If ultrasound is not able to pick up, in such cases we'll go to MRI. Otherwise, ultrasound only 95%. Okay. So the two answers for this question is ultrasound scan and MRI scan. CT high radiation we won't do. X-ray is also radiation modality, so we won't do. Hence the correct answer for this question is B and C only. Correct answer is B and C. Okay. So this is how we can exclude it. Friends, in this question what I want to say is, you must have some pre-existing knowledge. At least if you know placenta accreta spectrum ultrasound is best means, what you can do, you know, B is option. So you can remove the other option. So C and D will be removed here. Okay. A only will be removed here. So you will eliminate the options and come to a point where it will be easier for you to crack the MCQ and get the question right, which is very important. That will be determining your rank, right? So that's why. So while studying itself, try to remember certain things try to remember it very clearly so that you won't make mistakes in this question. Okay. Now we'll be decoding it. First I will tell you MRI. What is the role of MRI in placenta accreta, sir? It is the newer technique that is gaining wide acceptance in case of reproductive radiology that is related to female. It is used as the problem solving tool in obstetrics imaging when ultrasound is not able to give you much details. Indications can be fetal in case of equivocal anomaly in ultrasound scans. Okay, so placental issues like placenta percreta, placenta increta, placenta accreta. Okay, so in these cases what happens, sir? See, remember here there will be a decidua between the placenta part and the uterine. Okay, that intervening decidua will be absent. So what happens? The placenta will start getting attached to the myometrium and goes beyond, friends. Goes beyond. I'll show you an image. So what are the investigations, sir, we can use to find placental abnormalities? Like placenta accreta is transvaginal ultrasound, that is ultrasound, transabdominal ultrasound, Doppler imaging, that is all, and MRI. So remember, ultrasound and MRI are the answer. Here, the placenta, if it is only attached, remember the word attached to myometrium is accreta, into the myometrium is increta, penetrates through the myometrium is percreta. Mnemonic here, placenta attached to myometrium is accreta, into the myometrium is increta, penetrate through the myometrium is percreta. Okay, these are the images. Okay, let's say a scar was there and here the placenta getting attached, accreta, into the myometrium increta, through the myometrium, penetrate through the myometrium is percreta. Now let's get to our next question. A patient with RTA brought to emergency room, left-sided diaphragm was pushed up. Next step to be done. In the next step in management, which of the following is contraindicated is the question. Okay. So here they have given you a chest radiograph image, and in this image you are able to appreciate. I will go along with you. This is the right lung field, trachea, left lung field, that's all it is here, and the diaphragm has risen up. It should be normally at this level, but it has gone up to this level, and you are able to see the stomach bubble front. This is the air which will be present normally in the stomach, and this will be the fluid part which is present in the stomach. So this is the typical case of, remember it, the diaphragm has gone very up, traumatic because of RTA, the diaphragm going up, right, diaphragmatic rupture. Okay, in such a case, which of the following is contraindicated is putting an intercostal drainage. So if I put the intercostal drainage, it will go puncture the viscera which has come up. Okay, so it will puncture. That's why intercostal drainage is contraindicated. Little bit of a tricky question. Once you know this, you won't make mistakes. I'm sure about that. The other options like log rolling, okay, insertion of nasogastric tube, epidural anesthesia could be done, but intercostal drainage is a contraindication, because it will go damage the bowel, viscera, stomach part. Okay, that's how I have come to the answer of intercostal drainage. Next question, please. Okay, a 30-year-old primigravida, first time pregnant woman, 30-year-old, comes with 10-week pregnancy. Okay, so according to her LMP, it is 10 weeks, the uterine sizes. She's complaints of vaginal bleeding, okay, pain in the abdomen and vomiting. These are all clinches. Uterus is enlarged on per abdomen examination and appears to be 12 weeks. There is a discrepancy of 2 weeks. So according to our LMP, it is 10 weeks. On per abdomen examination, it appears 12 weeks. There is a discrepancy of 2 weeks in the early trimester itself, first trimester itself. So she is also having painless bleed per speculum. When we do a per speculum examination inside the vagina, she is having fresh bleeding from her os. Based on the ultrasound, most likely diagnosis is. It's a clear-cut question, friends. This is a case of hydatidiform mole, also known as molar pregnancy. It is not a blighted ovum. Okay. It is not a missed abortion. I will tell you how. Okay. In case of missed abortion and blighted ovum, there is no necessity of uterus getting enlarged in size. Okay, both are not favoring pregnancy. Then what is the necessity of uterus getting enlarged? No need. Placenta polyp. Placenta itself won't be developed at that earlier stage. Now, how come a polyp would be there? Hence, polyp is also removed. The typical classical answer is hydatidiform mole or molar pregnancy. Okay, let's discuss about it. The points which you must know at your level is you will be able to appreciate snowstorm sign on ultrasound. When I perform ultrasound of the uterus, inside the uterus there won't be fetus, right? It will be mole. It's a molar pregnancy, hydatidiform mole. In case of a complete mole, I will be able to see snowstorm sign. Okay, the uterine cavity will be filled with multiple fluid-filled thin-walled cystic contents. Inside the uterus, I will be able to see multiple fluid-filled thin-walled cystic contents, which will be black and white, right? It will be appearing like a snowstorm. When I perform a Doppler, why Doppler, friends? Because to look at the vascularity, the tissue has increased the vascularity. Next to point towards molar pregnancy. In case of what is partial mole, a gestational sac or fetal parts can be seen along with molar pregnancy. That is partial. So these one-liners are all asked in the past. Hence, I have added here. MRI is the modality of choice for invasive molar choriocarcinoma. Okay. So in the previous exam, what they asked is, in a patient with invasive mole, what is the modality of choice? MRI. In a patient with choriocarcinoma, investigation of choice? MRI. Okay. The metastasis from choriocarcinoma, that is inside the uterus, the metastasis will go up to the chest and the brain, and they are hemorrhagic type, friends. Remember here. Okay. These have all been asked in the past. So with this, friends, I come to the end of the discussion. So what I have done in this discussion is I have discussed all the radiology MCQs and the radiology integrated with first year, second year, third year and final year subjects. Okay. Hope it would have been a very informative session for you. With this, I come to the end of the discussion. Thank you, friends. Just go through each and every question. At least one time, follow me through the entire lecture so that you will understand why the examiners ask you such a question, why such options, why such confuses, what is the explanation, okay? And the next time, just revise through this slide so that you will never make mistakes in this question again, and that would help you in a better rank and better mark. See you on other side. On behalf of Speed, I want each and everyone who is looking through this video all the best for your upcoming exam, NEET PG 2022. I want you on the other side taking interview of you. Thank you, friends. And I want to particularly thank Dr. K. Vinayak Sendil sir, who had given me an opportunity in Speed for taking radiology classes. You can find my videos on the future aspect, and my dedication and thanks to my close circle of family members, my friends and well-wishers through whom I have been sitting here and taking lecture for you. Thank you, friends.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.